Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy to understand concepts. Did you know one of the most prescribed blood thinners in history started out as rat poison? That's right. Warfarin, a drug that has saved countless lives, was originally used to kill rodents. Its transformation from barnyard mishap to hospital staple is one of the strangest and most fascinating stories in pharmacology. In this video, we'll explore where warfarin came from, how it works in the body, and the key precautions and side effects to keep in mind. So, let's get into it. The story begins in the 1920s, on the prairies of the US and Canada. Farmers were alarmed, cattle were mysteriously bleeding to death, sometimes from the tiniest cuts or routine procedures like dehorning. The culprit turned out to be moldy sweet clover hay. Scientists eventually discovered that when this hay spoiled, it produced a compound that blocked blood clotting. Fast forward to the 1940s. Researchers at the University of Wisconsin isolated the active compound and named it dicumarol. By 1948, they successfully synthesized a more potent version and called it warfarin, a name inspired by the Wisconsin Alumni Research Foundation, or better known as WARF. But instead of going straight into clinical use, warfarin's first job? You got it. Rat poison. Only in the 1954 did it make its way as human medicine. One notable patient? U.S. President Dwight D. Eisenhower, after a heart attack. That moment catapulted warfarin into the medical spotlight. Now let's talk pharmacology. How does warfarin actually work? It acts as a vitamin K antagonist, which means it interferes with the body's ability to use vitamin K to activate specific clotting factors, namely factors 2, 7, 9, and 10. Here's how. In the liver, vitamin K is needed to carboxylate these clotting factors. This step helps them to bind to calcium and do their job in forming blood clots. Warfarin blocks the vitamin K epoxide reductase complex enzyme, which is responsible for recycling vitamin K into its active form. Without active vitamin K, the liver can't make fully functional clotting factors. The result? Your blood takes longer to clot. But it's not instant. Unlike heparin, warfarin takes 2 to 3 days to take effect because it only affects the production of new clotting factors, not the ones already in circulation. Warfarin can be a lifesaver. It is used to prevent strokes in patients with atrial fibrillation, treat deep vein thrombosis and pulmonary embolism, and protect patients with mechanical heart valves. But it comes with caveats. The biggest risk? Bleeding. This can range from minor bruises to life-threatening hemorrhage. And because warfarin has a narrow therapeutic index, the dosing needs to be just right. Too much and you bleed. Too little and you clot. That's why doctors closely monitor patients using the INR, or International Normalized Ratio. It's a simple blood test that measures how long it takes your blood to clot, compared to the normal range. The sweet spot? Usually between 2.0 to 3.0, depending on the condition being treated. Now, here's where things get complicated. Warfarin is highly sensitive to interactions with food, drug, and even supplements. Let's start with diet. Foods rich in vitamin K, especially leafy greens like spinach and kale, can reduce warfarin's effect. More vitamin K means more active clotting factors, and consequently less anticoagulant effect. Even grapefruit juice can cause trouble. It contains compounds that block cytochrome P450 enzymes, which are crucial for metabolizing warfarin. The result? Warfarin stays in the body longer, amplifying its effects. Next up, medications. Some antibiotics wipe out gut bacteria that normally produce vitamin K, making warfarin more potent and increasing bleeding risk. Some antifungals, such as fluconazole, inhibit CYP2C9, the enzyme that breaks down warfarin. This slows clearance, causing warfarin to stay in the bloodstream longer, increasing its anticoagulant effect and elevating risk of bleeding. The key takeaway? Small changes in diet or medications can have big consequences. That's why patients on warfarin need regular INR monitoring and close communication with their healthcare team. Now, let's talk about pregnancy, a time when drug safety is critical. Warfarin is teratogenic, meaning it can cause birth defects. The risk is highest in the first trimester, when exposure can lead to fetal warfarin syndrome, a condition involving facial malformations, underdeveloped bones, and neurological problems. Because of this, warfarin is generally avoided during pregnancy. Instead, doctors use low molecular weight heparin. It doesn't cross the placenta, making it a much safer alternative for both mother and baby. Warfarin may have started off as a rodent killer, but currently, it remains one of the most studied and widely prescribed anticoagulants. Today, newer drugs like direct oral anticoagulants are on the rise. They come with fewer interactions and don't require INR monitoring. But warfarin still plays a vital role, especially for patients with mechanical valves or severe kidney disease. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.